Hello everyone, welcome back. In my today's lesson, I'm going to talk about rheumatic heart disease in children. Rheumatic involvement of the cardiac valves is the most important sequel of acute rheumatic fever, and it is the second most common major manifestations of acute rheumatic fever after arthritis. The valvular region begins as a small varicle composed of fibrin and the blood cells along the borders of one or more heart valves. The mitral valve is affected most often. This is followed in frequency by aortic valve. Isolated aortic valve disease is rare and generally seen with concomitant mitral valve. And also right-sided heart manifestations are quite rare, and it is virtually only associated with left-sided valve disease with secondary right-sided heart failure. As the inflammation subsides, the varicle tends to disappear and it leaves scar tissue. With repeated attacks of rheumatic fever, new varicle forms near the previous one, and the mural endocardium and the chordae tendineae become involved. A single episode of acute rheumatic carditis often result in complete healing of the valvular region, while repeated episodes, especially involving previously affected valves, results in chronic rheumatic heart disease, which is the rationale for secondary prophylaxis after the first attack of acute rheumatic fever. The diagnosis of acute rheumatic fever requires the fulfillment of Jones criteria, with carditis being a major criteria. Previously, the diagnosis of rheumatic heart disease was based on cardiac auscultatory findings of mitral or aortic valve involvement, which was insensitive for early valve injury. This was based on endocarditis or valvulitis being seen more frequently in acute rheumatic fever compared with pericarditis or myocarditis, both of which lack more readily apparent physical examination findings. Currently, the Jones criteria involves the subclinical carditis in addition to the clinical carditis. That means subclinical carditis, it is echocardiographic evidence of mitral or aortic valvulitis in the absence of auscultatory findings and not consistent with physiologic mitral or aortic insufficiency. There is a method to identify physiologic from pathologic mitral or aortic insufficiency. So, despite the absence of clinical evidence, clinical murmur which shows mitral or aortic regurgitation, subclinical carditis, mitral or aortic valvulitis, which is detected on echocardiography that fulfills the pathologic criteria, can be taken as a major criteria of acute rheumatic fever. When we see patterns of valvular involvement in acute rheumatic fever, the first and the most common is mitral insufficiency. Mitral insufficiency is the result of structural changes that might include some loss of valvular substance and change to the subvalvular apparatus, including the elongation of the chordae, both of which can lead to valvular dysfunction. During acute rheumatic fever with severe cardiac involvement, heart failure is caused by a combination of mitral insufficiency with that of pancarditis. That means mitral insufficiency with involvement of the pericardium and the myocardium, in addition to the valves. Because of the increased volume load from the mitral insufficiency and the inflammatory process that damages the myocardium and the pericardium, the left ventricle dilates. The left atrium also accommodates the regurgitant volume. So, increased left atrial pressure results in pulmonary congestion and also of left-sided heart failure. Spontaneous improvement often occurs with time, even in patients in whom mitral insufficiency is severe at the onset. There is a spontaneous improvement. The resultant chronic lesion is most often mild to moderate in severity, and the patient is often asymptomatic. More than half of patients with acute mitral insufficiency will not have mitral insufficiency signs and symptoms of mitral insufficiency after 1 or 2 years after the acute attack of rheumatic fever, although they still may demonstrate a mild damage on echocardiography. In patients with severe chronic mitral insufficiency, pulmonary arterial pressure becomes elevated, the right ventricle and the atrium becomes enlarged, and the right side heart failure subsequently develops due to the left-sided heart failure due to severe mitral insufficiency. When we see the clinical manifestations of mitral regurgitation, the physical signs of mitral insufficiency depends on its severity. With mild disease, signs of heart failure are not present, and the pericardium is quiet, and the auscultation reveals a high-pitched hollow systolic murmur at the apex that radiates to the axilla. With severe mitral insufficiency, signs of acute or chronic heart failure might be noted. The heart is enlarged with heaving apical left ventricular impulse, and also apical systolic trill might be detected. The secondary sound might be accentuated if there is secondary pulmonary hypertension, and also a third heart sound or gallop is generally prominent. A hollow systolic murmur is heard at the apex with radiation to the axilla. When we see ECG findings of the patients with mitral insufficiency, normally the electrocardiogram and the chest radiographs are normal if the mitral insufficiency is mild. With more severe insufficiency, the ECG shows prominent, longer duration, and often bifid P waves. And also there is signs of left ventricular hypertrophy as we see on this ECG, and increased right ventricular hypertrophy if pulmonary hypertension is present. On chest radiogram, prominence of left atrium and the ventricle is commonly seen, and the former of which is better seen on lateral projection. This is the anteroposterior radiograph of the chest. It shows significantly enlarged left ventricle and the left atrium. On chest radiograph, this prominence of left atrium and the ventricle, it is more prominent if we took the lateral radiograph. And the congestion of the peripheral vessels and the signs of pulmonary venous hypertension may also be evident. Sometimes calcification of mitral valve is seen on the chest X-ray. When we see the echocardiography of mitral insufficiency, echocardiography in the acute phase may demonstrate enlargement of the left atrium and the ventricle. Left ventricle systolic function can be impaired if there is also a component of myocardial inflammation. And also mitral, the main signs of echocardiographic features of acute rheumatic carditis, mitral abdominal dilatation, chordal elongation, and also chordal rupture, which result in flail leaflet might be noted. The leaflet tips demonstrate a nodular appearance and also prolapse of the anterior mitral valve leaflet is seen. Doppler evaluation demonstrates the severity of the mitral regurgitation, and the chronic mitral insufficiency from rheumatic arthritis is characterized on echocardiography by leaflets and chordal thickening, chordal fusion, and also restricted leaflet motion, whereas the acute one is characterized by annular dilatation, chordal elongation, and chordal rupture, and also mitral valve leaflet prolapse. This changes that means the chronic mitral insufficiency changes such as leaflet and the chordal thickening, chordal fusion, and restricted leaflet motion. They may lead to stenosis, but poor coaptation of abnormal leaflet can also lead to variable degrees of regurgitation. Sometimes cardiac catheterization and other diagnostic modalities can be done, but it is not required most of the time. Severe mitral insufficiency may result in cardiac failure that might be precipitated by progression of the rheumatic process, and also if there is recurrent episodes of acute rheumatic fever with damage to the mitral valve, this causes severe mitral insufficiency progressively, and this causes the onset of triggers the onset of atrial fibrillation and also other arrhythmias, and sometimes infective endocarditis might be seen. The effects of chronic mitral insufficiency may become manifest after many years, and it includes left ventricle and right ventricular failure, and also atrial and ventricular arrhythmia. When we see the treatment of mitral regurgitation due to rheumatic heart disease, in patients with mild mitral insufficiency, prophylaxis against recurrence of rheumatic fever is that's the only thing required, in addition to the typical treatment of acute rheumatic fever. That means in addition to the acute treatment such as antibiotics, monthly antibiotics, also bed rest, also aspirin, if needed, prednisolone. In addition to those things, prophylaxis against recurrence of rheumatic fever is all that's required. For more significant insufficiency, as we have said, corticosteroids, prednisolone for 2 to 6 weeks can be given. Treatment of complicating heart failure, arrhythmia, and infective endocarditis, they should be treated accordingly. And also, due to the severe mitral regurgitation, there is left ventricular enlargement. To reduce this, to reduce workload, we should have to give afterload reducing agents, such as angiotensin converting enzyme inhibitors or angiotensin receptor blockers. They reduce regurgitant volume. Since they are afterload reducers, they reduce regurgitant volume, and they also attenuated pathologic compensatory mechanisms and they preserve left ventricular function. But these have not been significantly changed the natural history of the disease. But they support the heart, they decrease the workload of the heart, even though they might not significantly change the natural history of the disease. Diuretics may also be provided some symptomatic and clinical benefits. Preload reducers such as diuretics, furosemide, and the like can give symptomatic and clinical benefit in selected cases. In rare cases, if there is uh, pulmonary arterial hypertension, phosphodiesterase inhibitors might be helpful. Surgical treatment for mitral insufficiency is indicated for patients who, despite adequate medical therapy, have persistent heart failure, and also there is significant dyspnea with moderate to mild exercise, and also if there is progressive cardiomegaly, often with pulmonary hypertension, despite maximum medical therapy, if there is the symptoms, that is an indication for surgical intervention. Most of the time, angioplasty provides good results in most children, whereas valve replacement might be required in few children. In patients with prosthetic mitral valve replacement, prophylaxis against bacterial endocarditis is needed for dental procedure, as the routine antibiotic taken by these patients for rheumatic fever prophylaxis are insufficient to prevent endocarditis. So, in addition to medley, benzodiazepine or amoxicillin to prevent recurrence of rheumatic fever, we should have to give additional antibiotics to prevent endocarditis if they are going to have some dental procedure that involves the gingiva. Additionally, current recommendation suggests selecting different class of antibiotics for the procedure. Rather than just increasing the dose of penicillin, it is best to use another class of antibiotics. It's important to remember that all attempts should be made at maximizing medical management of severe mitral insufficiency during the acute phase of the disease process before considering surgical intervention and before sending such child to the cardiac surgical center. Because medical treatment have a good prognosis than surgical intervention. Surgical interventions have a poor prognosis and increased risk of reoperation when performed during the acute phase. The other complications of chronic rheumatic valvular disease, mitral stenosis. Mitral stenosis of rheumatic origin results from fibrosis of the mitral ring, commissural adhesion, and also contracture of the valve leaflets and the chordae and also papillary muscle over time. This is a chronic process and it often takes decades for the lesion to become fully established, although the process might occasionally be accelerated in frequent recurrent attack of rheumatic fever. Rheumatic mitral stenosis is rarely seen during childhood, and it's most of the time seen during adolescence. Significant mitral stenosis results in increased left atrial pressure and subsequent enlargement and hypertrophy of the left atrium, and also it can cause secondary pulmonary venous hypertension, increased pulmonary vascular resistance, and overt pulmonary hypertension. Right ventricular hypertrophy and right atrial dilation issues are followed by right ventricular dilation, tricuspid regurgitation, and also clinical signs of right-sided heart failure might appear during the latter time. When we see the clinical manifestations of mitral stenosis, generally the correlation between the symptom and the severity of the obstruction is good. The more the severe the obstruction, the more the patient becomes symptomatic. Patients with mild stenosis are asymptomatic, whereas more severe degrees of obstructions are associated with exercise intolerance and dyspnea. Critical lesions can result in orthopnea, paroxysmal nocturnal dyspnea, overt pulmonary edema, as well as atrial arrhythmia. When pulmonary hypertension has developed, right ventricular dilation may result in functional tricuspid insufficiency. This causes hepatomegaly, ascites, and peripheral edema. Sometimes hemoptysis can be seen in such a child due to rupture of bronchial or pleurohilar veins and occasionally pulmonary infarction in some children. So hemoptysis can occur. Jugular venous pressure is increased in severe disease with heart failure, tricuspid valve disease and regurgitation, or severe pulmonary hypertension. In mild disease, heart size is normal. However, moderate cardiomegaly is typical with severe mitral stenosis. Cardiac enlargement can be massive when atrial fibrillation and heart failure supervenes. A parasternal right ventricular lift is palpable when pulmonary hypertension is high. And also the principal auscultatory finding of mitral stenosis is a loud first heard sound, and also an opening snap of mitral valve, and a long, low-pitched rumbling mitral diastolic murmur with presystolic accentuation at the apex. The mitral diastolic murmur might be virtually absent in patients who are who have significant heart failure from the elevated left ventricular feeling pleasure. Sometimes, if there is severe mitral stenosis, a holostolic murmur secondary to tricuspid insufficiency might be audible at the left lower sternal border. If there is also pulmonary hypertension due to complications of mitral stenosis, pulmonary component of S2 is accentuated. When we see the chest X-ray, moderate to severe lesions are associated with radiographic signs of left atrial enlargement and the prominence of pulmonary artery and also right-sided heart chamber dilatation. Severe stenosis is associated with a redistribution of pulmonary blood flow so that the apex of the lung have greater perfusion. This is the reverse of a normal. This is due to the redistribution of pulmonary blood flow. As you see on the picture, the left atrium is enlarged, displacing the left atrial appendage outward. This is a red arrow. On the right side of the heart, a double density consisting of overlapping of the left atrium with the black arrow and the right atrium with white arrow. This is overlapping of the left atrium and the right atrium. The left main bronchus is also elevated by the larger left atrium, pushing it upward. When we see the ECG, ECG shows prominent and notched PUFs and also varying degrees of right ventricular hypertrophy. Atrial fibrillation and the other atrial arrhythmia are common late manifestations, and echocardiographically it demonstrates thickening of mitral valve and also chordal apparatus as well as restricted motions of the valve. There is a typical echocardiographic finding, that is elbow or dog-leg appearance of the anterior leaflet of the mitral valve. It aids in the distinction of rheumatic valve from various forms of mitral stenosis. So this is a way to the way to differentiate mitral stenosis from that of rheumatic disease from other cause of mitral stenosis, other congenital cause of mitral stenosis. Doppler can estimate the transmitral pressure gradient and can underestimate the gradient if there is left ventricular dysfunction. Otherwise, Doppler echocardiography estimates the severity of mitral stenosis by estimating the transmitral pressure gradient. When we see the treatment, intervention is indicated in patients with clinical sign and the hemodynamic evidence of severe obstruction, but before the onset of the severe manifestation. Pharmacologic therapy, that means diuretics and the beta blockers, can be considered, but it is generally used only for symptom control and much less often in children. Surgical valvotomy or balloon catheter mitral valvuloplasty generally yields good results, and the valve replacement is avoided unless absolutely necessary. Balloon valvuloplasty is indicated for symptomatic, stenotic, pliable non-calcified valves of patients without significant atrial arrhythmia or thrombus. The next valve that's affected by rheumatic valvular is aortic valve. In acute rheumatic aortic insufficiency, poor coaptation of the leaflets or leaflet prolapse is seen. Chronic rheumatic aortic insufficiency leads to sclerosis of the valve and results in distortion and retraction of the cuspis. In both settings, the regurgitation of blood leads to left ventricular volume overload with dilatation and also hypertrophy of the left ventricle, because it attempts to compensate for the excessive volume overload. Combined mitral and aortic insufficiency in the acute phase of rheumatic fever is much more common than aortic valve involvement. When we see the clinical manifestation of aortic insufficiency, symptoms are unusual except in severe aortic insufficiency or in the presence of significant concomitant mitral valve involvement or myocardial dysfunction. The large stroke volume and the forceful left ventricular contractions may result in palpitation, and the sweating and heat intolerance are related to excessive vasodilation. Dyspnea on exertion can progress to orthopnea and also pulmonary edema, and angina might be precipitated by heavy exercise. Nocturnal attacks with sweating, tachycardia, chest pain, and hypertension might also occur. There are different peripheral signs of aortic insufficiency. The pulse pressure is wide with bounding peripheral pulse, that means a water hammer or a Corrigan pulse. Systolic blood pressure is elevated and the diastolic pressure is lowered. In severe aortic insufficiency, heart is enlarged with an left ventricular apical heave. A diastolic trill may also present. The typical murmur begins immediately with SC2 and continues until late in diastole. The murmur is heard over the upper left and also mid left sternal border with radiation to the apex and also upper right sternal border. It is characterized by high-pitched blowing quality and easily audible in full expiration with the diaphragm of the stethoscope placed firmly on the chest and also patient leaning forward. An aortic systolic ejection murmur is frequently heard because of increased stroke volume. Just to mention some few peripheral signs of aortic insufficiency. As we have said, the first one is wide pulse pressure with bounding peripheral pulse, that means a Corrigan pulse. The other is a Demusset sign. Demusset sign is head bobbing during with each heartbeat, to and fro head bobbing during each heartbeat. The other is Muller sign. Muller sign is a visible pulsation of uvula during systolic activity of the heart. The other is Quincke sign. This is a capillary pulsation seen on light compresses of the nail bed during the heartbeat. The other is Traube sign. This is systolic and diastolic sounds. That means a pistol shoot over the femoral artery. Druge's sign is a Broods heard over the femoral artery on light compression by stethoscope. Heel sign is a popliteal cuff pressure exceeding brachial pressure by 16 mm of mercury or greater. These are just few peripheral signs of aortic insufficiency, and there are so many peripheral signs of aortic insufficiency in addition to those things. When we see the chest radiograph, this is a radiographic feature of aortic regurgitation. Absence of pulmonary venous hypertension or pulmonary edema until late in the course of the lesion. Moderate to severe cardiomegaly when there is severe aortic regurgitation and also left ventricular enlargement and also enlargement of the ascending aorta and the aortic arc. This is the ECG feature of patients with aortic regurgitation. Normally, when there is mild aortic regurgitation, ECG might be normal, but in advanced cases, in like this, it reveals there is a sign of left ventricular hypertrophy. This is a strain pattern. There is a strain pattern and also prominent P waves. This is the science of electrocardiographic science of aortic regurgitation. Echocardiography shows a dilated left ventricle and the diastolic mitral valve flutter or oscillation caused by aortic regurgitation flowing, hitting the valve leaflet. The aortic valve may demonstrate regular or focal thickening, decreased systolic excursion, and also a coaptation defect can be seen. And sometimes leaflet prolapse is seen. Doppler evaluation demonstrates the degree of aortic insufficiency. Sometimes other imaging such as magnetic resonance imaging or cardiac catheterization might be needed to further delineate the degree of insufficiency. When we see the prognosis and the treatment, mild and moderate degrees of aortic insufficiency are well tolerated. Unlike mitral insufficiency, aortic insufficiency does not generally regress. Patients with a combined lesion, for example, if the patient has mitral insufficiency with that of aortic insufficiency during the acute rheumatic fever, if we see 1 year later, mitral regurgitation signs might subside and then we might only have aortic valve involvement. So, unlike mitral insufficiency, aortic insufficiency does not generally regress. Treatment consists of angiotensin converting enzyme inhibitor or angiotensin receptor blocker to decrease afterload and the prophylaxis against acute rheumatic fever recurrency. Surgical intervention, which is typical aortic valve replacement, occasionally can involve aortic valve repair, should be done in well advance of onset of heart failure. And also if the patient shows pulmonary edema, angina, or when signs of decreasing myocardial performance become evident. The other thing is right-sided valvular involvements are rare in patients with rheumatic heart disease. For example, tricuspid valve involvement it is very rare. It's rare both in acute and the chronic stage of rheumatic fever. Tricuspid insufficiency is more common, secondary to right ventricular dilation, which results from significant left-sided cardiac lesion. And also pulmonary valve involvement is almost rare. It's secondary to, if it occurs, secondary to acute rheumatic fever, and which damage the left side valves. When we see the prognosis and the treatment, mild and the moderate degrees of aortic insufficiency are well tolerated. Unlike mitral insufficiency, aortic insufficiency generally does not regress. Patients with combined lesion during the episodes of acute rheumatic fever may have only aortic involvement 1 to 2 years later. Treatment of aortic regurgitation consists of afterload reducing by angiotensin converting enzyme inhibitor or angiotensin receptor blocker, and also we should have to give prophylaxis against acute rheumatic fever, recurrence according to the guideline. Surgical intervention, which is typically aortic valve replacement, but occasionally aortic valve repair should be done in well advance of the onset of heart failure, pulmonary edema, angina, or when signs of decreased myocardial performance become evident. The right-sided valvular involvement, such as tricuspid valve disease or pulmonary valve disease, it is more common secondary to right ventricular dilation resulting from significant left-sided cardiac lesion. Otherwise, primary tricuspid valve involvement and the pulmonary valve involvement due to rheumatic valvular disease is rare. So, thank you. Don't forget to like and subscribe this channel for other videos regarding pediatric disorders.